Hi, so today we're going to be reviewing the Kaiser study, and this goes over information about what employers are offering in today's market. They're also reviewing uh, deductibles, co-pays, are employers offering HSAs, self-funded plans, babysitting my dog here. So you'll see I have a Chihuahua and a cattle dog. So you'll see some movement there in the background. Um, it's the Employer Health Benefits Study of 2021. So of course we had to complete a full year of 2021 before we can really look at it and see what happened and try to predict or troubleshoot what is going to happen in 2022 in regards to businesses and the decisions that they're making out there in the marketplace. So let's get to it. Okay, so today we're going to be going over deductibles and co-pays and trying to digest what happened in 2021 and prior years as well to see where the market is headed in 2022. So average annual worker and employer, where am I going to put myself here? Average annual worker and employer premium contributions for family coverage 2011, 2016, and 2021. You'll see in 10 years ago, the worker contribution, which is this base number, this darker number, is 4,129. The employer contribution was 10,944 for a total average price of $15,000. In 2016, 5 years later, that's increased 20%. The premium total increased 20%. The worker contribution increased 28%. In 2021, we saw another 22% increase over that 5-year period and a 13% increase for workers. The percentage of covered workers enrolled in a plan with a deductible of $2,000 or more. So, where am I going to put this head of mine? We've got small firms in this top line here. So in 2009, we've got 16% offering a plan with a $2,000 deductible or more. So it wasn't so common as it is today. You've got nearly 50%. See the chart pretty consistently going up here in all three categories. And then large firms are the bottom here. 3% in 2009. And then today, about 1 out of 5 are offering a plan with a $2,000 deductible or more. Among firms offering health benefits, which month are most people offering it? I think most people know this intuitively, even if you haven't really thought about it too much. January. This is because deductibles reset every January. So if you do have a $2,000 deductible, that deductible is not per incident like it is in car insurance. It's per calendar year for most plans. Some are plan year, but most are calendar year. So to avoid any pitfalls or avoid the majority of pitfalls with changing carriers and changing plans, a lot of employers choose to enroll January 1st, because if you're enrolling, let's say in the middle of the year, 6/1, and you have employees that have already met their deductible and max out of pocket, the employee may be able to transfer their deductible over to the new plan, but not always the max out of pocket. Maybe they've have 100% coverage because they've met their max, and they transfer to a new plan in the middle of the year, they have to start over again. So a lot of employers want to avoid that, as all that, like I said, as many pitfalls as possible. So a lot of them are starting in January. And then of course we have this December bucket that we had some, when healthcare reform came out, ACA, Obamacare, whichever term you want to use, came out, a lot of employers moved to a December 1st to avoid changes that came in the coming year. So they were locked into older plans that were not subject to ACA or Obamacare and moved to a December so they could lock in, extend the older plans for at least an 11-month period before transitioning into the regulations surrounding Obamacare and ACA, the Affordable Care Act. Okay, so average annual premiums for single family coverage from 99 to 21. So back in 1999, single coverage was on average less than $200 a month. So 2,196 for family, it was just under $6,000 a year. And then we go forward, you can see this is a very consistent increase over time that we've seen since 1999. Today, the average is $7,739. And for a family, it's $22,221 for an annual premium. Now, these are averages. It includes all industries, so manufacturing, medical, white collar, blue collar, gray collar, as well as all different types of plans. So HMO, PPO, EPO, POS, self-funded, fully insured, all of the insurance categories. So I believe, as I've said before, this is not a tool for budgeting per se. If you want to budget, you should get a quote specific to your demographics and specific to your area. This is multiple different areas, multiple different industries, multiple different demographics, a bunch of different types of plans. This is to simply show what the increases have been over time and this steady increase that we're seeing. And I believe, as you saw, if you watched my previous presentation that went over Cigna and some inflation numbers in regards to health insurance and medical inflation, that we are seeing, or no, that was my ease presentation, we are seeing for the first time since I believe 1981, that CPI data is coming in higher than medical inflation. That has not happened in quite some time because, as you'll see this graph here. Okay, so percentage of firms offering health benefits by size, region, and industry in 2021. We've got firm size 3 to 9, so less than 10 employees. About 50% are offering benefits, and then all large firms over 200 and more, it's about 99%. A lot of that is because of the regulations surrounding ACA. Smaller firms, 3 to 199 workers, about 60% are offering insurance benefits. Okay. Lots of numbers for a lot of people. Sometimes you just got to take a breath, take a little brain break, walk around the block, pause my video, throw me in your earbuds, and let's keep grinding. Okay, average monthly worker premium contributions for single family coverage since 1999 to 2001 or 2021. Since 1999. So premium contributions for a family was $129 a month. Today it's about $500 a month for a family. Employees are paying about, we're paying about $27 in 1999. Today, they're paying about $110 per month. So we call this benchmark information, and that way you can look at what you're doing, look at your goals. That's one of the things I help my clients with specifically, is we look at what are your goals and what are the reasons why you're even offering, why are you spending so much money on this health plan? I mean, as you can see, health insurance is one of the top costs for employers. And a lot of employers are offering it to attract and retain the best talent that they can. So we look at that bucket that they're putting towards, that bucket of money they're putting towards medical, and really figuring out how to attract and retain those employees. And so when we're looking at these monthly rates, and we can get industry specific because, you know, manufacturing is going to be different than tech, let's say, $108. If you're more than $108 and you're having a hard time recruiting that key employee that you've been looking for 6 months, this might be one of the reasons. Okay. Average annual worker and employer contributions to employees and total premiums for single coverage since 1999 to 2021. Employer contribution was 1,878, and this is dark. Employers are paying more. A lot of insurance plans require the employers to pay a minimum of 50% of the premiums. So part of the reason you see this is because it's a requirement by the insurance carrier in their underwriting process. They want to make sure that these employers that are offering coverage are, in fact, going to have good enrollment numbers. And one way to do that is to increase the employer contribution. So the higher the employer contribution, the better the enrollment, the better the plan performs, because you don't just have people that desperately need the coverage that may have cancer or chronic condition. You get healthy people enrolling as well. A lot of times, if someone's really healthy, they may skip the enrollment and do a health plan if they think they can get away with not having health insurance. So that's one reason why you see this bias towards employers having a larger chunk, because it's a requirement by the insurance carriers. And then you also see it because the labor market is getting more competitive and employers are seeking to improve their benefits as much as they can to attract and retain top talent. So in 2021, you've got $6,440 in the dark blue and $1,299 for employee contributions. Okay, so what is that? What is the average plan? So if we're looking at the average cost, we want to look at what most employees and what most Americans are experiencing as far as plan design. So some employees have a $0 deductible, some have a $7,000 deductible. So here it's looking at 2006. Back then, the average deductible was between $303 and $584. And so this is average deductible among covered workers who face a deductible for single coverage. And then the light blue is average deductible for single coverage among all covered workers. Okay. So they may have a single deductible or combined deductible. So there's two different deductible categories. So they're just really trying to create a range here so you can see what most employees are experiencing as far as the deductible is concerned. So today it's between $1,400 and about $1,700 deductible. Among covered workers who face a deductible for single coverage, average general annual deductible for single coverage by firm size. So this helps us see what small employers are doing versus the large employers, and the yellow in the middle is all firms. So we started out around $500 as a deductible in 20 in 2006. And then in 2021, we've got between a $2,500 deductible and about a $1,200 deductible. For the larger firms are able to offer lower deductibles for similar costs in most situations than smaller employers for the same amount of money. Among covered workers with coinsurance for hospital admission or outpatient surgery, distribution of coinsurance. So coinsurance is the percentage that a member pays towards their claims after they've met their deductible. So for instance, if an employee has a $2,000 deductible, they go to the hospitalization costs $5,000. The employee pays 100% of that first $2,000 because that's their deductible, and then they have $3,000 remaining. What percentage is that employee going to pay towards that $3,000? A lot of plans are 20%, so they would pay 20% of that remaining $3,000 plus the $2,000 of the deductible. Okay, so this is asking, what are most employees experiencing when they go into the hospital after they've met their deductible? What is that percentage of coverage? Is the insurance company paying 80% and the employees covering 20%? Is it 10%? Is it 30%? Or is it more than 30%? This more than 30% is on the right. It's the dark. You can see most employees are not paying more than 30% in coinsurance. Now, one thing to keep in mind is that this is from Kaiser. Kaiser mostly has HMOs. They do not offer a lot. They don't have a high PPO enrollment. So you have to keep that in mind when you're looking at this. If we look at data that is specific to PPOs, this number is going to be a lot higher. It's going to be categories of 50%, 40%, 30%, 20%, and 0 to 10. You're not going to see as many people in this 0 to 10 category. You're going to see people more in this 35% to about 20% category in coinsurance. Okay, so just keep that in mind. This is mostly HMO focused data. 0 to 10%, so you've got about 20% of the population in that category. And then the big chunk of people are paying between 10% and 20% towards their coinsurance. And then you've got about 10% that are paying between 20 and 30% in coinsurance. So covered workers with copays and coinsurance for physician office visits, average copayments and coinsurance by plan type 2021. So we've got this HMO category at $20. Okay. And the coinsurance is not applying here for these people. So their average, most employees, if they're on HMO, are paying $20 for a primary office visit. And for a specialty visit, like a dermatologist, endocrinologist, all those ologists, they're paying between $30 and $40 copays, or maybe a $35 copays. You don't see many plans with the 36. PPO, they're paying about 25, around $30 for a primary care visit and $40 to $50 for a specialist. POS plans, point of service, not the other acronym, with CACA in it, are paying about $30 copays for primary care, about $50 copays for a specialist, and in high deductible plans, there usually is a percentage. The copay usually applies after the deductible is met. So that's one thing employees really need to know if they're enrolling on these plans, most high deductible health plans. And after that, that's when the copays kick in, even for office visits, where a lot of traditional PPOs and HMOs and point of service plans, you do not have to meet your annual deductible before you experience these copays for office visits. A lot of times the deductible is waived for office visits, where with the high deductible plans, the deductible is not waived for those copays. So those employees are paying the deductible, and then they're either paying about 18 to 20%, or they have a copay of around $20 to $30. For specialty care, employees are paying about 20% if they're on a high deductible health plan, to about $50 if they have a copay arrangement plan design. So if they look at all plans, it's about a $25 copay for primary care with a 20% coinsurance, and specialty is about a $40 copay with 20% coinsurance. Okay, among covered workers with a copay for primary care, office visit, distribution of copays by plan type. So this is just showing the difference between HMOs, PPOs, point of service, all plans. So as you can see here, HMOs have a little bit richer copay arrangement and coverage in general, which is why when I said when we're looking at these deductibles and these coinsurances, we want to keep in mind that Kaiser, when we're looking at the average, you want to keep in mind that Kaiser has mostly HMOs. So that's going to weight the data towards the richer side when we're looking at this benchmark data specifically to HMOs. So if you have a PPO, it's better to look at something like this that breaks it out into type. So HMOs, you can see about a quarter of them pay $10 or less on their copays, where with the PPOs, only 5% of the population is paying that little. Most people have a $20 to $40 copay for their primary care, okay, with the PPOs. Among covered workers with a copay or coinsurance for physician's office visits, average copayment and coinsurance from 2006 to 2021. So you've got a primary care visit here versus specialty. So this is just showing a slight increase over time. 2006, it was about $18 for a primary care visit, and a specialist was 23. Back then, they didn't even record the coinsurance, which is sweet. Where now employees are seeing coinsurance in lieu of a deductible, in lieu of a copay. So not all plans now have copays for office visits, where before 2006, most plans had copays for and no coinsurance at all for office visits. So that's just all this is showing here. In 2021, we see about a $25 copay for primary care and about a $40 to $45, $50 for specialists. Okay, and I'm just going to take a break in the middle of this. This is a lot of numbers, so I just want to remind you, I am looking forward to meeting you. There will be a link down below to message me if you have a question or you want a copy of this report. Also, I have a questionnaire you can complete it for employers who want to work with me. I have a questionnaire for individuals who want to work with me. I do not have too many openings for the individual category. I don't do that as much as I do the employer piece. Register for a meet and greet that we're going to do in Arizona. This is exciting for me. We want to get out there and meet new people. So we're doing this in Arizona, and I look forward to meeting you. Okay, let's continue. Again, if you need to get in those earbuds and walk around the block to wake yourself back up, or get down and do 10 push-ups, refresh your mind. Among firms offering health benefits, percentage that offer high deductible health plans, HRA, or an HSA qualified high deductible plan. So high deductible plan / HRA is in the light blue, and HSA qualified high deductible plan is in the dark blue. Most people have an HSA over an HRA. If you don't know the differences, that is a separate, it would be a separate presentation. I have not recorded a presentation like that yet, I don't think, and I may work on that at a later date. If you need that information now, again, just message me and we can do a private Zoom call to go over that together. Okay, among firms offering health benefits, percentage that offer high deductible by firm size. So 3 employees to 200 employees is in the dark blue, and 1,000 or more employees is in the light blue. So the dark blue, you can see about 1 out of 5 are offering that, with a slight increase since 2005. And the larger employees are increasing that at a faster rate than the smaller employees. So you've got about a 66%. So 2/3, 2 out of 3, where 1 out of 5 with the smaller firms. Distribution of covered workers facing cost sharing formulas for prescription drug benefits. So this is just breaking it up into tiers. So over time, we've seen an increase in tiers. And now I see some plans with like 8, 10 tiers. So there can be a lot of tiers and tiers within tiers. So 4 or more tiers is the most prevalent that we're seeing. And a lot of plans now, even though they may be 4 tiers, like I said, there's tiers within tiers. So I would really even call that, if you have 2 tiers in one tier, I would call that 8 tiers, right? So I'd almost have this in a higher categories, you know, like 5 tiers and so on. So we're really seeing this increase. This isn't demonstrated here as much. Kaiser has a different structure than some other insurance companies. Kaiser is the hospital. They are the health management provider. So they employ all of the doctors. So they don't have as many tiers as some other insurance companies might, because they have a policy, whereas if a doctor writes you a prescription, there is no pre-authorization process, because their employees are trained as to which prescriptions to write for each specific condition. And they view it as, if a physician writes you a prescription, they fill it under that category of prescription, whether it's generic, brand, or off-label, so, or non-formulary, which a formulary is just a list of approved medications by the insurance carrier. Oftentimes the newer prescriptions don't have time to be evaluated and put onto the formulary, so newer prescriptions are going to be non-formulary, or a non-formulary is going to be, there may be 100 different medications that treat a condition, and the insurance company evaluates all 100 and determines which ones are going to be in their formulary. They're usually the most cost-effective treatments in their eyes. So they put those in their formulary, and then the rest are put into their non-formulary list. Non-formulary tier generally are higher copays. So with that, again, we have to be mindful of where the information is coming from. This is not from UHC. This is not from Blue Cross Blue Shield or Anthem. So they're not going to have as many tiers because of the structure of their health delivery system, because they are the only one that is the insurance company as well as the provider. So keep that in mind. Percentage of covered workers enrolled in a self-funded plan by firm size. So they're including level funded, which is available for smaller employers. It's a baby step version for self-funding. Self-funding is when an employer decides to drop the insurance company and design their own plan and pay for all the claims out of pocket on their own. Now, there is structure behind these plans. You do have to build out a plan design and a plan document in order to be a health plan by law. So there is quite a few steps to fall into compliance to be able to write this off as a benefit to the employees and follow all the legislation surrounding health plans. But as you can see, about 65% of all employers are doing some sort of a self-funded arrangement. Plan funding. So again, this is just me. I like to look at definitions. I've learned that every company has a slightly different definition of even common terms. So I don't like to assume definitions. I always like to review them, make sure that I am not misunderstanding what the insurance carrier or any other party means by by their definitions, especially when looking at these surveys. We may assume that when they say self-funding, it means you know, they have a stop loss carrier, for instance, and doesn't include level funding. So the way I know that it does include level funding is because it says that here, and it does define exactly what they mean by self-funding in the Kaiser survey. So I'll just read this briefly, and you can always fast forward if you're not interested in this self-funding piece. Many firms, particularly large firms, choose to pay for some or all of their health services of their workers directly from their own funds rather than purchasing health insurance for them. This is called self-funding. Both public and private employers use self-funding to provide health benefits. Federal law, the Employee Retirement Income Security Act, ERISA Act, attempts self-funding plans established by private employers, but not public employers. For most state insurance laws, including reserve requirements, mandates, premium taxes, and many consumer protection regulations, 64% of covered workers are in a self-funded plan in 2021. Self-funding is common among larger firms because they can spread the risk of costly claims over a larger number, the rule of large numbers, and workers and dependents. Some employers which sponsor self-funded plans purchase stop-loss coverage to limit their liabilities. So as an insurance expert, when I hear, oh, they're self-funded, I assume that they are in this first category, but they continue. In recent years, a complex funding option, often called level funding, it's been around longer than the last couple of years, but okay, has become more widely available to small employers. I do not agree. I believe it's become less available because of certain regulations that have been put in place, make it less appealing, but perhaps the word's gotten out more about level funding. But okay, level funded arrangements are nominally self-funded options that package together a self-funded plan with extensive stop-loss coverage that significantly reduces risk retained by the employer. It just means they have a smaller stop-loss deductible. 38% of covered workers in small firms are level funded. So that's this small firm definition is 3 to 199. Again, everybody defines small employer differently. Some insurance companies say it's 1 to 50. Others say it's 1 to 99. Others say it's 1 to 250 employees. So again, super important to know what each insurance company that you're working with is defining as a small group. Self-funded plan, 64% of covered workers are in a plan that is self-funded, similar to percentage 67% last year, so it hasn't changed too much. The percentage of covered workers enrolled in self-funded plans is similar to percentages 5 years ago, which was 61%. So it went from, it's been fluctuating between 60% and about 67%. 10 years ago, it was at 60%. As expected, covered workers in large firms are significantly more likely to be self-funded than small firms. So it's 82% versus 20%. All right. Percentage of covered workers enrolled in self-funded plans by firm size is, so 999 is 63%, 1,000 to 5,000 is 86, 5,000 or more is about 90% that are under 200 employees are about 20%, and all large firms are at about 82. Region, Northeast. Part of this is because, believe it or not, the West is actually less expensive. Washington, Oregon, they have more options. Arizona, Nevada have more options than like an Alabama or a Mississippi. Groups that are based out of New York have employees all across. New York has quite a few options available. They may not have the same provider availability in New York as in North Carolina, South Carolina, Florida, Mississippi, etc. Okay, so if even though those they're based in New York and they might have quite a few options, they have employees spread out all over. So then now their options become more narrow. So because of that, going into a self-funded plan may give them more options than going direct to an insurance carrier, give them more flexibility. They may be able to carve out one plan with a specific network for a specific region, get region specific and things like that, rent multiple networks, where if they go to an insurance company directly, they're trying to fit a square peg in a round hole and their costs become inefficient. Hopefully that makes sense. Among large firms offering health benefits to active workers, percentage of firms offering retiree health benefits. So this is not retirement plans. This is not 401ks or anything like that. This is specifically retiree health benefits. So we've seen a large decrease since 19 employers were offering retiree health benefits. And today it's, 1 in 5, 1 in 4, something like that. Okay, so we're getting towards the end of this survey. It's one of the larger surveys, so it takes a little bit more time to digest. These are not all of the slides or all of the graphs and not all of the information. I cherry picked what I felt was the most representative and interesting information to pare it down for you so you could get through this in about a half an hour. It was about a 200-page document that I reviewed for you and condensed down, so hopefully you find that valuable. The rest of it is about biometric data, wellness plans, behavioral health, which is mental health services, and so on. Among firms offering health benefits, what percentage of firms are offering the opportunity for biometric screening? So in the last 10 years, we've seen health plans add wellness plans to their employee population, which I am a huge fan of. I think it's a wonderful mindset shift for employers to go through to look at their population and say, how can I help my employees focus on wellness rather than just treating conditions? Yes, treating conditions is super important, but how do we become proactive? How do we help employees catch problems before they get worse? So one thing that biometric screenings do is they help catch people that are pre-diabetic before they become diabetic, help catch cancer sooner and other conditions. So in 2021, about 1 in 4 people, employers are offering some sort of a biometric screening, okay? And employers that are 5,000 or more are about 50% are offering biometric screenings. There are biometric screenings that can be mailed directly to the employee. Okay, it used to be we would get a big truck that would come out and, we'd have wellness fairs, employees would gather all together and get their blood work done together and create this wonderful team environment. And some employers can still do that. However, you can't get a stool sample, things like that. Also, there are employee populations that are resistant to this. They don't want their employer to have information specific to their health conditions. So going into it, we really need to educate the employees and let them know that there are privacy laws put into place where there's a barrier between your individual data and your employer. So it's not your employer taking your stool sample and analyzing it in their own lab at their business. It's going to a third party that is protecting that information, just as if you were to go to a doctor, right? If you're going to go to a doctor, even though your health plan is paid for by your employer, that doctor isn't sharing your personal data with your employer. It's the same thing here. It's just the employer is paying the provider directly because it's more cost effective, usually, to pay the doctor or the lab to come in or to buy these mail home packets in bulk rather than the employee buying it individually and having those sent out to all the employees. And then the lab collects the data and the lab sends the results directly to the employee, and oftentimes have follow-up calls with a coach to help them digest the information and work towards being healthier and what they can do to be healthier. And then the data is put into an aggregate report. So it's not John Doe has prediabetes, or John Doe is in the overweight category, or, it doesn't name anybody specifically. It just says 5 out of the 20 people that were tested for diabetes are pre-diabetic, or, it just gives this very general aggregate data picture to the employers. And the purpose for that is so that the employer can see, oh, wow, a quarter of my employees are pre-diabetic. I probably shouldn't order donuts every Friday anymore for everybody. Maybe we need to pick something else. Okay. Among firms offering health benefits, percentage of firms offering specific wellness programs to their workers by firm size region in 2021. Okay, so again, these are, and I like this slide because it shows some of the categories for wellness. This is in particular to physical health. There are other categories. There's financial wellness as well, which I think is super important, talking to employees about how to manage debt, pay off debt, how to save, why saving for retirement is a good idea, even just putting, $50, $100 a month. The younger you start, showing people how that compounds over time. And also getting the tax benefits from doing that as well, if you have a 401k or retirement package. However, I think a lot of people forget about smoking cessation. This is one of the ways that I personally quit smoking. Is I was managing the health benefits for my employer when I started at my first big girl job out of college. And I put in a wellness program. We were really small, but I was very interested. It was a new thing. I wanted to learn more about it. And I am someone who learns by doing. So I put in this program and I ended up going through it myself. Said, yeah, the smoking cessation and these programs don't work. I'm like all negative about it. I'm like, well, if they can get me to quit smoking, it's going to be really good, right? It's going to prove that this thing works. And if it doesn't work, then I can poo-poo it and not show it to anybody, right? Well, over time, it ended up working and I did quit smoking. And the catalyst for that was the smoking cessation program and also the weight loss program. So I signed myself up for a weight loss program and I didn't think I would learn anything. I was super critical, I was super negative, and I had first quit smoking and I gained weight because I wasn't smoking anymore. And so then I signed up for the wellness weight loss program, and they gave me a coach to check in with. At first it was once a week, and then I think it was once every other week or once a month. I forget the exact, or maybe it was once every 6 weeks for a while. And she put me in my place, man. Like she really gave me some questions that made me think and changed my mindset about food, at least started me on the path to going. It shook me up going, wait, maybe I don't know how to lose weight. Maybe I don't know as much as I thought I did. So that was really fun. Other lifestyle or behavioral health coaching, the percentages are here. Small firms is about 40 to 50%. Large firms is about 70 to 85%. Okay. And the West Coast is winning here. I'm not surprised. We see this in actuarial data. We call them the red states. It has nothing to do with political, has to do with the obesity chart. So there's a chart, I should find it and do a presentation on it, where it's a map that shows from light to red. So you've got like yellow, orange, dark orange, light red, and then dark red. And the dark red states are Alabama, Mississippi, the Carolinas, all those southern states. And we find that the wellness plans aren't very prevalent there. And the culture is not that of which is geared towards exercise and eating vegetables. That's more the West Coast is leading the charge there. Okay. And also, it correlates to insurance premiums. I think a lot of people believe that when they move to a state like Mississippi, that everything is going to be less expensive. And then they move and they see that their health insurance costs just doubled, especially when you're moving from like a coastal community like California. You know, you think everything's more expensive in California. Well, because of the health culture in California and the low smoking rates, it's actually less expensive in a lot of regards. Okay. Among firms offering health benefits that shopped for a new plan or insurance carrier, the percentage of firms that changed insurance in the past year. So I didn't have a lot of this. I'm having more of it this year. I found that with my clients specifically, nobody wanted to make any changes. Everybody wanted to try to keep everything as consistent as possible, particularly with their doctors. They wanted to make sure that employees could maintain their same doctors throughout the pandemic. And even though they stayed with their insurance carriers, they may have upgraded their plans or made richer options available, made up some buy-up options for their employees. So that was more my personal experience. But this is showing across the board, 1 out of 4 changed insurance carriers, and even 1 out of 3 in large firms changed insurance carriers in the past year. So I was surprised to see this because I didn't have that same percentage. Okay, so among firms offering health benefits, percentage of firms whose plan with the largest enrollment covers telemedicine. So telemedicine really opened up once the pandemic started. Legislators made it easier for groups like Intelidoc to operate between state lines. So a doctor that was in Florida could now get on the phone with someone in California, which was not the case before. Before you had to have a license in that particular state to practice medicine. So now telemedicine is available for any doctor or any licensed physician to perform across state lines. Intelidoc is the most popular. Personal anecdote, I'm not as happy with Intelidoc as I once was. Intelidoc, when it first came out again, I was really excited. I was one of the first ones to really get behind it and pitch it to my clients and show them the value. And it was a great cost savings. And once employees started using it, they absolutely loved it. I've seen a downgrade in service through Intelidoc recently. I believe it's because they expanded so quickly. I don't know if they're just not vetting their doctors as well as they once were, but the last couple of times I've called in, I noticed, I'm like, wow, this is like 20% as good as it. I mean, when it started, it was amazing. I absolutely got amazing doctors on the phone, and the sign up to get a check-in was wonderful and very consistent. And this last couple of times I've tried, I've had some technical issues and things like that. So it makes me wonder if there's going to be another provider that pops up that does it better than Intelidoc, but we'll see. They're just so big and they've been doing it for so much longer. But anyway, 2015, about 25 to 30% were offering a telemedicine, and now it's 95%. Part of this is because a lot of insurance carriers have paid for Intelidoc. They buy Intelidoc services for their clients, and they incentivize their clients to use it because the insurance carriers save so much money when somebody goes and uses Intelidoc and skips the urgent care. As you know, when you're sick, you call your primary care physician and they can't see you for 2 weeks or a month. And you're like, well, 2 weeks or a month, I'm not going to be sick anymore. So then you end up going to the urgent care and the urgent or the emergency room, which is even worse. The insurance company does not want you to go to the emergency room for the sniffles. So they always want to try to redirect clients for cost savings to a teledoc. Also, for me as a patient, every time I go to the emergency room, I feel like I come back with another illness, to go in with COVID and come back with the flu. I go in and come back with, an eye infection. It's like, so I've always felt that it's safest to stay at home and make sure that you are calling your doctor. A lot of doctors are now doing visits over the phone as well. So taking advantage of that instead of sitting in, a medical gown for 2 hours in a room with your butt on that parchment paper stuff, just not a pleasant experience waiting on that doctor. You might as well just be sitting at home and not exposing yourself to other germs and things that are out there. Among firms offering health benefits, changes the firm made since the beginning of COVID to meet mental health needs. So as I've talked about in previous videos, is mental health, anxiety and depression is up, I think 44%, something like that. So it's something that employers really need to be mindful of. And a lot of insurance plans already have these built in because of the Mental Health Parity Act. And a lot of it is just making sure that your employees are aware that they can use these services. A lot of plans have an EAP, an employee assistance program, where they can get financial advice. They can get mental health care and counseling over the phone for free, or even in-face visits for free. A lot of these counselors are doing Zoom meetings as well as an option. So just making sure that the barrier to entry is lowered and employees, we remove some of that fear that's associated with going to counseling or therapy for the first time. Okay, among firms with 50 or more employees offering each of the following programs, percentage that may be changed due to COVID. So we've got mental health and substance abuse coverage up 39%, and 55% wellness programs, and 65% in telemedicine. All right, so again, just if you need help with any of these for your business, or if you have any questions, please shoot me an email or click one of the links down below of what you're interested in. I appreciate you hanging out with me. Hopefully you are feel more equipped to know what's going on out there in the insurance market and more educated as to what to do with your insurance plan and how it works. And thanks for hanging out with me today. We'll see you in the next one.